how would you decide which patients are going to need more rapid forms of respiratory support, such as but not limited to high flow nasal cannula up front? What kind of pushes you in one direction or another?
Thank you, Ryan. So specifically, it really goes to your clinical judgment. So in the beginning of the COVID pandemic, there was a lot of uncertainty, and there was a severity that was seen in the respiratory population, and many of them were intubated. And we know, and it might coming from the New York City metro area, a very high morbidity mortality associated with those that did get intubated and placed on ventilators. So my background is actually pediatrics, and we had taken a little bit different approach in that regard. So it's more your clinical judgment and your tolerance of the individual patient in front of you. We had used a lot of high flow because it's part of the modalities that we use with our underlying respiratory disorders that we see routinely outside of COVID. So we had escalated onto high flow pretty easily and pretty readily. And at that time, we had gone above and beyond and continue to do so the flow rate that is potentially recommended before you transition onto another modality. We also use BiPAP pretty readily, as long as we were set up with the filters to appropriately capture those and had the patients placed in, ideally, in the airborne precautions rooms. So I think it's quite a challenging question to ask and a challenging question to answer, because it depends upon what your experience is, your skill set, the resources you have, and your comfort level. So most oftentimes when you're talking about an approach to a critically ill patient and you're a non-critical care provider, it's going to be your comfort level and the access that you have.
Oh, absolutely. And you know, it is interesting to think about how this has evolved over the course of the pandemic. Very early on, there was a lot of, I would say, push or interest in avoiding these non-invasive modes of oxygenation support, of high flow and non-invasive positive pressure. And I think a lot of that came out of the experience with other severe coronaviruses, particularly in Eastern Asia, from SARS and then also MERS in the Middle East and in South Korea, where they had some outbreaks. And those experiences of nosocomial transmission of those viruses in that setting kind of bled over into early concern with COVID. And very early on, I suspect all of you had the same experience. There was a lot of interest in early intubation, and it turns out that we can obviously get away and avoid that in many patients with things like high flow. Dr. Scott, Dr. Griffiths, do you have any additional thoughts about that?
Sure. So I think Maureen is very much on point. It has everything to do with your environment, because you could take the same patients in a small ED that doesn't have a lot of capacity to monitor patients, where there's a large influx of these critically ill hypoxemic folks that tax your respiratory therapist, your physician, your nursing. And that's very different than, a place that has a lot of monitoring and staff. And it depends on where in the pandemic you were. New York, obviously, in March and April, and Miami this summer, not as bad as New York, but still very bad for us, with 60 to 100 patients waiting to be admitted in our main ER. So that definitely has an effect. The other piece, of course, is the experience of what you've seen. If you've seen 5 of these patients or 10 of these patients versus having seen 100, I think it gives you some equipoise to know to some degree where you can sit back and avoid intubating them. And I think we'll probably go down that road in this conversation, but I think it's really important for the folks to understand that mechanical ventilation in any form is bad. It's a life-saving therapy. It's a therapy we use for operations to allow people to get through a surgery, so the surgeon can work on them without them moving, with paralyzation. But at the end of the day, there's nothing good about being on a ventilator. And I think pretty much that's just some quick thoughts in a segue.
Well, that's
I would
perfect.
also like to add, I'm sorry, I would also like to add that having the patient self-prone may prevent them from even having to consider mechanical ventilation. We've used that in quite a few of our patients who are on high flow or even BiPAP, trying to get them to self-prone when they're off of those devices, or even on the high flow nasal cannula, has really prevented some patients from being put on mechanical ventilation.
I agree with you. Everybody, who's experienced in this kind of care, I think has done that. There were some recent papers out of Europe that showed no benefit with respect to mortality and preventing intubation. And I can't quote those studies. There's just too many studies coming out all over the place, and papers and research letters and all these things that we're overwhelmed with, but certainly advantageous. And to comment on that, some people do really well on like their left side or their right side, which is a trick a lot of intensive care folks have used for years to take advantage of VQ mismatch, or just a disimbalance between the lung and the blood flow. So yeah, I would agree with you. I just want to point out that everything works to a point.
No, exactly, and that's certainly been my clinical experience as well. That there is a lot of heterogeneity in how different individuals respond to proning, but it is rarely a bad idea to try.